Okay, so what we're going to be doing today is going over some important things with obstetrics. So first of all, we need to understand gravida and para. Whenever you present a pregnant woman to a doctor, you need to find out how many times she's been pregnant and what happened with all those pregnancies. Okay, so this is the way they do it. They have gravida, which means total of times the woman has been pregnant. Okay, doesn't matter if it was pregnant with octuplets or if the pregnancy ended in a miscarriage. Doesn't matter. How many times has she been pregnant? Okay, not counting the individual babies. So, for example, if she was pregnant with octuplets, that would not count as 8 pregnancies. That would count as 1 pregnancy. Okay, so gravida, and then you put a number there. The next one is para. Para means the number of times that the pregnancy has gone to 20 weeks to delivery or whatever. At least 20 weeks. At least 20 weeks. Yeah, make that distinction there. Not exactly 20 weeks, but at least 20 weeks. So if it didn't go beyond 20 weeks, then you wouldn't count that there. Okay. So so put a little 20 inside of here so you can remember 20 weeks or more, greater than 20 weeks. So then you put a little number in there. Okay. However, there's other ways of tracking this as well. There's 4 numbers that can go after this. 1, 2, 3, 4. You scratch out that one when you do this. And remember the letters T-PAL. Okay. So when you have a baby, you have a little. Oops, that would not be the right letter. When you have a baby, you have a little pal, a little T-PAL. A little pal you can have tea with. So this stands for number of full-term pregnancies. That's what the T stands for, is number of term. And so you put a number there. You put P means preterm. Okay, that's right. Preterm deliveries. So you put a number there. So how many deliveries were before the baby was considered full-term? And then how many abortuses? So that could be either abortions or miscarriages. We don't distinguish between the two in this one. Basically, the baby didn't make it to the 20 weeks, or didn't make it full term, rather. The baby died before before it was delivered. Okay, and then the total number of living. How many living children do you have? And you put that number in there, and then that gives the doctor an idea of what's going on. So, for example, if a woman comes in and she's G 1, but she is P8, you'd say, she must have had octuplets. Okay, that'd be kind of simple. But if she was G8, P1, abortuses 7, living 1, or something like that, then you could say, oh, wow, okay, so she had 8 pregnancies. She had 1 delivery. I guess I should have put a T there. Anyway, hopefully you get the idea. I don't want to go into this too much. It's kind of confusing, but hopefully you get the idea. Just basic gist. Okay, moving on. Now the developmental age. So developmental age is different from gestational age. There's developmental age and there's gestational age. That's a D. One is based off of when did fertilization occur. So that means exactly when did the sperm hit the egg, when did you ovulate, and all that stuff occur. And the other one's based off of your last menstrual period. Okay, so when did you start bleeding last? So it's kind of hard to know when this happens, right? When developmental age happens, that's not a very easy thing to know. So you'd have to have some kind of ovulation kit or some kind of way to monitor when ovulation occurred, so you can know when the sperm and egg hit. The last menstrual period, knowing when bleeding hits, that's easy. And that's usually what the doctor is going to ask for, and what he's going to want to know is when your last menstrual period was, because then based off that, he can calculate your gestational age. So if he knows when your last period was, you'd say, okay, how many weeks has it been since your period? That's your gestational age. All right. Next here is fundal height. Okay, so fundal height, pretty straightforward. That's a woman's belly. That's her belly button. So when you look in here in the tummy and you feel, not look, but you feel that the fundus goes up to the umbilicus, then you'd say that must be 20 weeks along. Okay, so you think of maybe you can draw it this way. So here's the big O is the uterus, and then here's an outline of the baby here. There's a little baby, has his head, his little arms coming down. And that 2 represents the little baby in there. So 2, 0, 20 weeks up to the umbilicus. Okay. All right. So then fetal heart tones with a Doppler. So when can you pick up fetal heart tones with a Doppler? This is going to be at 10 to 20 weeks. And so here is the Doppler machine. It's got this. It's 10 to 12 weeks, if that's what I said. There's a little Doppler machine, and it's got a little cord coming off the back. And notice this looks like a 1 and a 0 because indeed it is 10 weeks that you can pick up the sounds of the Doppler. Okay, so 10 weeks, 10 to 12 weeks is when you can pick up the sounds of the Doppler. So think about 10 weeks, 10 to 12 weeks. That's when, before that, the baby's heart is just too small. So 10 to 12 weeks is big enough that you can actually hear it. Okay, next is quickening or appreciation of movement. So the way we're going to think about this one here is we're going to think of a 7. So I'm going to go ahead and draw in here. How should I do this? I'll just delete it all. So we're going to think of a 7 for 17. And here's the mommy's tummy. And inside the mommy's tummy is this little leg sticking up. Boom, little baby's kicking. The baby's kicking and he's also punching. Here's his arm, there's his leg. So here's the baby down here. Okay, and that 1 and that 7 means 17. So you can hear the baby at about 17 to 18 weeks. Okay, 17, 18 weeks is when you can first, not hear the baby, feel the baby. Okay, so that's when you can feel the baby is about 17 to 18 weeks. And this is the mommy. And well, that's taking up our whole tummy, but you get the idea. All right, so next here is the ultrasound. So the ultrasound, you measure different things at different points, and this kind of has to do with kind of where the baby's at. So originally, the baby looks like this little like squirrely thing like this, right? And so you measure. And this is like, it's just a way of thinking. This isn't totally accurate, but way of thinking of it. So when it's this little squirrely thing, you could just measure it from its crown, which is its head, to its rump, which is this little stumpy thing. And that's 6 to 12 weeks. Okay, so 6 to 12 weeks, and oddly enough, this kind of looks like a little 6. See that? Crown to rump. So 6 to 12 weeks is when you measure crown to rump length. And you do that with the ultrasound. And then you can also do a biparietal diameter and a femur length and abdominal circumference at 13 weeks. Okay, so let's go ahead and draw what that's going to look like. So this is at 13 weeks. So one thing that's nice about this is you've got 1 and you've got a 3. And this one, think of it as a little femur, okay? You're going to measure the femur length, and also this thing here is the baby's belly, okay? So this baby's got a big belly, and then there's its femur. So 1, 3, 13 weeks, femur and abdominal circumference at 13 weeks. So you're measuring the abdominal circumference with this big belly. It's got 2 rolls in the belly, and 1 is the bone. All right, now next is the ultrasound movement of gestational age is reliable during the first trimester. So it's you break up the pregnancy into 3 groups. You call it the first trimester, second trimester, and the third trimester. And all the babies are pretty much the same size in the first trimester. And so when you're going to use these measurements in the ultrasound to measure how big the baby is, it's the most reliable in this trimester. Now later on, some babies get big, some babies get medium, some babies get small, and so later on, it's harder to calculate accuracy based on these measurements in the second and third trimester. Okay, so next, what we have is we're going to be talking about beta HCG. Okay, here's that beta symbol. We've got HCG. Okay, so what this is a this is a little protein that you can measure in the woman's blood, and you can determine what's happening with the baby. Pretty cool. So first of all, if a woman is not pregnant, she should not have any beta HCG in her system. Okay, there are some really rare circumstances where that might be not the case, apparently with some veterinarians. So don't worry about that. Basically, the woman doesn't have beta HCG, she's not pregnant. Okay, so if she does have beta HCG, then she most likely is pregnant or she was pregnant. Okay, the only way to know whether she is or she was is by taking more than one measurement of beta HCG. So let's say you got one measurement. Let's say the measurement was 1,000. Okay, so if the baby's growing normally and everything's fine, and this is the first trimester, the beta HCG should double every 48 hours. So every 2 days, this should go to, let's say you take it on this day, and then you wait 2 days. So 1 day, 2 days, 3 days, and then after the second day, then you measure it again, and now it's 2,000. You'd say, hey, this baby's growing great. Everything is normal. But if it's not about doubled in 48 hours, then you'd say, this baby's not growing the way it should be growing. Something may be wrong. Something is up. Maybe the baby has passed away, you know. Or if it's like way higher than that, sometimes you can worry about like a molar pregnancy or a twin pregnancy or something like that. Molar pregnancy is where the baby's not really actually going to survive, not growing properly. It didn't really grow into a baby. So that's a little bit about beta HCG. So apparently beta HCG is going to peak. So it gets to its highest point. So your beta HCG is doubling. Oops, it's doubling every 2 days. Boom, 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 boom. And then once it gets to, this is a 1 week. Once it gets to 10 weeks, it's going to reach its highest point. And its highest point, it's going to be 100,000 units. Okay, of beta HCG. That's going to be the highest point. And then it's going to decrease down. It's going to decrease during the second trimester, and then it's going to level off during the third trimester. So 10 weeks, and then this is the, let's say, sorry, this is not, I didn't do that correctly, but hopefully you heard what I said. Okay, so decreases during the second trimester, and then it levels off during the third trimester. So ultrasound is a way of diagnosis of pregnancy. So the most common way of diagnosing pregnancy is going to be the beta HCG, but you can also diagnose it by ultrasound. And they say that the gestational sac is visible by. So remember, the baby grows in this little sac, and you're not going to be able to see that. It's so small that you can't even see it until it gets to 5 weeks. Once it hits 5 weeks, it should be about big enough that you can see something there. And that's going to be 5 weeks based on the gestational age, not the developmental age. Remember, the gestational age is going to be based off of the last menstrual period, whereas the developmental age is based on when ovulation hits. So last menstrual period happens before the fertilization. Okay, so next is just understanding that the beta HCG range at 5 weeks. So 5 weeks should be about 1,000 to 1,500. So that's about where it should be at 5 weeks. And that's the earliest you can see it. So if they see the little sac there and the beta HCG is at that level, then they'd say, everything is normal and it looks great. Okay, talking a little bit about the normal physiology of pregnancy. So there is going to be some change in renal flow, and there's going to be some change in glomerular filtration rate. So hopefully you remember what a glomerulus is. So inside of your kidneys, you have these glomeruli, and there's a tube that brings the blood in, and the blood gets all swirled around in here, and then the tube that goes out. And while the blood's getting all swirled around in here, it strains some pee-pee that is collected in these tubes, and then the pee-pee is drained out. Oops, and then you pee out the pee-pee. Okay, so they can measure the rate at which the glomerulus is filtering out the pee-pee from the blood. They call that the glomerular filtration rate. So like how much pee you're making, and they also can measure the renal flow. Okay, so what happens to renal flow and what happens to glomerular filtration rate during pregnancy? Well, it appears that it follows a graph something like this. So if I were to put this, and then I were to say, put this at about plus 40, and that's percent of change, by the way, so percent plus 40% change. And then down here I put weeks, and I put 36 weeks here, and I put about 24 weeks here, and I put 12 weeks here, and I put 0 weeks there. You're going to see the renal flow do something like this. And it gets up to about its highest, about 12, comes across, and then after 24 it starts going down again. That's what you're going to see renal flow do. Renal flow percentage. So it's going to increase, okay? It says here that the renal flow increases 25 to 50%. So that's about approximately 4. So renal flow increases 25 to 50% during pregnancy. Well, what about glomerular filtration rate? That does something similar. It goes up like this, and then it looks like it hits about there, and then it just kind of peters off. So this increases early, then it plateaus, glomerular filtration rate. Okay, what about the uterine height and the body weight? So the uterus, the uterine height, so what are we looking at here? We're looking inside of the mommy's tummy, and you know, this would be like a normal mommy over here. Uterine height's going to be really small normally. Well, in a pregnant mommy, the uterine height's going to get much bigger. So it increases from about 60 to 70. So this is 60 to 70 grams. It's going to increase, 70 grams. It's going to increase to about 900 to 1,200 grams. So that's a much increased uterus. Sorry, that was weight, not height, sorry. And then you've got body weight. And usually a woman is going to gain about 25 pounds. So 25 pounds. And that's in her, of course, her uterus got a lot bigger. She's going to get a lot more fluids. Breasts are going to increase. Usually they get some more adipose tissue as well. All these things are going to increase. So that 25 pounds is divided up throughout the body. Okay, so they also say 25 pounds are 11 kilograms, depending if you're not from America. Okay, there we go. Increase. So there's that. Now let's talk about prenatal care a little bit. Well, maybe I'll stop this video here. I'll keep going. What the heck? I'm having fun. All right, so prenatal care. So for prenatal care, the goal of prenatal care is to prevent, diagnose, and treat conditions that can lead to adverse outcomes in pregnancy. So basically, we try to do certain things to take care of this mother so that the baby can grow healthy. So there's a certain parameter of weight gain. How much weight should she gain? How much is not enough? I mean, so normally they gain about 25 pounds, but what if they only gain 1 pound? Well, that's concerning, because then that means either the uterus isn't getting big enough, the breasts aren't getting enough, she's not getting enough fluid. Something's wrong here if she only gains 1 pound. So let's go ahead and put the parameters here. So so normal, it's got to be somewhere between 1 kilogram, and kilogram is this isn't perfect, but close to half of a pound. Okay, so it'd be the same 1 kilogram or close to 2 pounds. That's not perfect, but roughly close. 1 kilogram to 1.5. So if you double that, that's like 3. Okay, so 3 pounds, 1.5 kilograms. So every month during pregnancy, she should be, so this is, per month, per month she should be gaining 1 to 1.5 kilograms. If it's less than 1 kilogram, not enough. If it's more than 1.5, it's too much. So less than this would be inadequate. Okay, whatever. And greater than this would be excessive. Okay, got that? Now, what about body mass index? So we don't want, I mean, for example, if a mother was anorexic, that would be unhealthy for the baby. So where should the mother's BMI be? So we consider a BMI. So now we're looking at BMI for the mother. Where's the ideal BMI? A BMI that's considered underweight, so I'll put the lower range right here, is a BMI of less than 19.8. Okay, that's a point. And that's about the same thing as, well, I won't worry about that. It says 12 to 18 kilograms. Acceptable is going to be, 19. So this goes up to 26. Greater than 26. So somewhere in this range, basically somewhere between 20 to 25. I mean, if you round, but not round, but just choose easy numbers. 20 to 25 BMI is pretty close to being healthy. Now, if it gets above the 25, really it's above the 26, but then you start worrying. You consider it overweight if it's somewhere between 26 to 29. So this is normal. This is good. This is not good. 26 to 29 BMI. Not good. And then really, really overweight is a BMI of 29 and up. So not good during pregnancy. So hopefully you can see that. So roughly below, I should do it this way. Oh, that was a mistake. So if you take the BMI here and it's like less than 20, that's not good. This is the magic number here, about 20 to 25, 26. 20 to 26 is where you want it to be. And really it's 19.8, but whatever, you get the idea. Okay, so next we have nutrition. So let's talk a little bit about nutrition. So for nutrition, we have several things that we need to really take care of. And these things are folic acid, iron, calcium, vitamin D, and vitamin B12. Let's talk a little bit why these things are important. Okay, so if the woman doesn't get enough folic acid, the baby is at risk of something called spina bifida, where basically its spinal cord doesn't form properly. It's like sticking out of the back. It's a bad thing. Iron is really important for making blood. Now remember, you're making blood for the baby too, making lots more blood. So you need iron to supply all that blood making. Okay. Calcium, baby's got to grow a lot of bones, so you need some calcium. Vitamin D is basically goes along with the calcium. If you don't have the vitamin D, the calcium doesn't work, so they go hand in hand. And then vitamin B12 is really important for cellular division and brain development, that sort of thing, because the baby's growing a lot of new neurons. So those are the things you really want to look into. And I was hoping I could make some kind of fun thing here. So A for acid, B for B12, C for calcium, and D for vitamin D. So remember your A, B, C, Ds when it comes to nutrients. And of course I left out iron in there. So let me write this one more time. So you've got A for acid, folic acid. You got B for vitamin B12. You got C for calcium, not vitamin C, but calcium. And you got D for vitamin D. And then you've got I for iron. Okay, so remember those, A, B, C, D, I. Okay. How much, though? How much of each of these things do you need? Well, let's write them over here. So let's start with over here with the folic acid. So how much folic acid do you need? It says, oh, you know what else I forgot here was calories. Let me say real quick. Well, I'll get calories in a second. Okay, so folic acid supplements. Looks like they should be taking 0.4 milligrams a day. 0.4 milligrams a day. Okay, 0.4. How much vitamin B do they need? They need 2 those units, it's micrograms, a day. How much calcium do they need? So 1,300 milligrams for a day for people that are under 19. And if they're over 19, they only need 1,000. So we could say you need more when you're little because you're still growing your own bones. So that's how much they need, and the units there is going to be milligrams. And then vitamin D is 10. Oops, I made that the wrong way. Sorry. Micrograms per day. So 0.4 milligrams, 2 micrograms, 1,300 milligrams, and 10 micrograms. Yeah, good luck remembering all that. I mean, I guess you can think of some way. The calcium is the highest, which kind of makes sense because the baby's got a lot of bones to grow. So that's 1,000 milligrams. So lots and lots of calcium. So remember the big number was the thousands. And really, one way to remember this is to remember it by units. And if you just remember that this, well, I don't know how I want to do this exactly, but yeah. So sorry. You also need a lot of folic acid because the baby has a little spinal cord to make. So that's 0.4 milligrams. And then you've got the microgram units for B and D. Those are kind of smaller sorts of amounts that's needed. Hopefully that helps a little bit with remembering that. Now, what about calories? How many calories does the woman need? Oh, sorry, first, I forgot about iron. Let's not forget about iron. So then we've got iron down here. And iron, you need 30 milligrams a day. 30 milligrams a day. Okay. Or 150 milligrams of iron sulfate. So it's either 30 milligrams of elemental iron or 150 milligrams of iron sulfate. So you need more if it's iron sulfate, probably because there's sulfate mixed in with the iron, and that's going to make it more milligrams. Okay, so now, what about calories? She's going to need an extra 100 to 300 kcals a day. So 100 to 300. 100 to 300 kcals. Kilocals or something. Kilocals a day. When she's breastfeeding, she'll need 500. Okay, so 500 kilocalories a day when breastfeeding. But when pregnant, 100 to 300 extra. That's not total, that's extra. Okay, so if normally she was on the 2,000 or whatever, add on an extra 100 to 300. She's breastfeeding, add on an extra 500. How much exercise? It says 30 minutes of moderate exercise daily. Moderate exercise means we're not running a marathon here. We're not sprinting crazy. It's basically like one way of thinking of it is exercising to the point where you could still talk just fine while exercising. So it's not like out of breath, starving for oxygen kind of thing. Okay. Cardiovascular. So this next one, what happens to the mother when she's pregnant? I'm going to put my book over here because it's on the other side now. When the mother is pregnant, what happens to the heart? So there's the heart, cardiovascular. Okay, the blood pressure. The heart rate is going to gradually increase 20%. So heart rate is going to increase 20%. Well, the mom has to pump more blood because she's also pumping for baby now too, right? Blood pressure is actually going to decrease. Now this seems weird because the mom gets more blood when she's pregnant, right? So if the mother gets more blood when she's pregnant, then why does her blood pressure decrease? Well, there's more than one factor at play when it comes to blood pressure. It's true, one factor with determining blood pressure is the amount of blood, but the other factor is how dilated or constricted her blood vessels are. Okay, so during pregnancy, the woman releases signals in her body that cause all of her blood vessels to go from being normal to being really expanded. So all of her veins get really expanded. Okay, she has to have more blood in her system. So with that really expanded blood, you see more varicose veins and things like that, and it actually drops the blood pressure a bit. So if normally she was at like 120, she might be at like 110 when she's pregnant. Okay, goes down. What about stroke volume? So stroke volume is the amount of blood that's pushed out through the aorta with each pump of the beat, or pump of the heart rather. So stroke volume. So stroke volume increases. And the maximum that it increases is at 19 weeks. It's going to increase, and then it's going to plateau a little bit. It doesn't say how much it increases here, but we just understand that stroke volume increases, which makes sense. You've got more blood, so that means more blood has to be pushed in the heart. So the heart rate increases 20%, and the stroke volume increases as well. So not only is the heart beating more quickly, but it's also pumping more fluid out as well. Now, what about cardiac output? CO, cardiac output. It rises rapidly by 20%. Then gradually increases an additional 10% by 28 weeks. So total cardiac output increases is 30%. So, but the first 20% is pretty fast, and then the last 10% on top of it is by 28 weeks. So cardiac output increases. Peripheral venous distension, progressive increases to term. So venous distension, you already explained that. That's it increases. Okay. Peripheral vascular resistance. This totally makes sense. If the blood vessels are bigger, is there going to be more resistance? No, there'll be less resistance. So obviously the peripheral vascular resistance is going to decrease to term. So now let's talk about the lungs a little bit. So with lungs, we have the following occurring with the mother. So we've got the respiratory rate. The respiratory rate is going to stay the same. I believe it's usually like 16. I'll use a different color now. I'll use purple. So 16. So respiratory rate, same. Tidal volume. So tidal volume is the amount of breath in a normal breath. So just me not going like that's not tidal volume. Tidal volume is just the normal breathing that's occurring. How much is in the normal air in and air out? That is going to actually increase. The mother's going to increase that by 30 to 40% rather. So that increases a bit. Next we have expiratory reserve. So this actually makes a lot of sense. When the mother breathes out as much air as she possibly can, the expiratory reserve is how much air is still left in the lungs. So let's look at this. Let's draw a picture of mommy here. So here's mommy's tummy, and here there's the chest, and in here are these lungs, okay? So as baby gets bigger and bigger and bigger, baby's going to push on these lungs. That means there's going to be less volume available in the lungs. So when the mommy breathes out all of her air, there's going to be less air in there less air in there for the expiratory reserve. So it's going to gradually decrease as the baby gets bigger, as I showed there. And then vital capacity is going to stay the same. Vital capacity is like how much total in, total out. It's going to stay about the same. And the respiratory minute volume is going to increase by 40. 40 for basically how much Respiratory minute volume. Okay, so that's like how much the mother breathes in a minute. I think something. Anyway, I don't know. I don't remember exactly the correct physiology. But that's going to increase, which makes sense. The mother has more blood and everything. She's got to breathe more. She has more cardiac output, and this blood needs to get oxygenated. Okay, so now let's talk a little bit about blood. So what's happening with the blood? We talked about the heart rate and the heart. We didn't talk about the blood. So here is the blood. Oops. That's blood for you. So how much volume? Blood volume is going to increase 50% by the second trimester. What about hematocrit? So whenever they look at blood, they try to measure, say they have a test tube of blood. Not all of that is blood cells. So they try to measure how much of this is blood cells, how much of this is white blood cells, and things like that. And I can't remember, it's either 45% or 55% is red blood cells. Sorry, one of those two numbers is right, I believe, but I don't remember. Somewhere it's pretty close to 50%. That is going to decrease slightly, okay? Which seems strange. Wait, why do we want the hematocrit? Why do we want the amount of red blood cells to decrease? We don't necessarily. It's just that the mother is getting so much more volume and everything in there. It's hard for her body to keep up with red blood cells. So the hematocrit isn't the amount of red blood cells in her body. It's that if you were to extract some of her blood and you were to say what proportion of this is fluid, or plasma, and what percentage of this is red blood cells, and how much is white blood cells, and blah blah blah, whatever. You look at the ratio. The ratio is less red blood cells per unit of blood, but overall, the woman has like increased by 50% the amount of blood in there. So she is actually getting more red blood cells, but her hematocrit is decreasing, which means most of what she's gaining is fluid, not blood. But it says it only decreases slightly, so it's still about close to 50%. What about fibrinogen? So fibrinogen is one of these clotting factors. It increases, so that means the woman can clot more easily. And I thought that happened with estrogen as well, which I don't know if it's related. And then you've got electrolytes, and those stay the same. It's a good thing, too, because those are pretty delicate as far as what's appropriate. All right, now let's look at gastrointestinal changes that happen in the woman. So gastrointestinal changes. For that, let's use brown. So GI changes. So the sphincter tone, I'll just draw a little anus there. That's going to decrease. Sphincter tone decreases. And the gastric emptying time, which means like the amount of time she makes poop, is going to increase. So her sphincter tone is looser, and the amount of times that she empties her bowel is going to increase. All right. Now let's look at factors that cross the placenta. Ooh, this is really interesting. So I might actually do this on the next video. I think I'm going to stop this video here. This video's gotten pretty long.